up and get started. Hello, hello, everybody. Happy Monday, post Thanksgiving. So good to see everybody. I'll give you a minute to get connected. It is so great to have you joining us. My name is Anissa Mitchell. I'm with PMD Alliance, and I want to welcome you to our program today, Why Say Yes to DBS. Before we get started, I want to just invite you to open up your chat box and give us a shout out. Where are you joining us from? And if you are in the US, happy post Thanksgiving. Hopefully you had a great Thanksgiving, and feel free to ask your questions throughout the program today. We are going to be having a conversation with someone who has recently undergone surgery for deep brain stimulation along with his physician. So this is our second part in a 3-part series that we're doing with our partners at Medtronic. And today we're going to be discussing deep brain stimulation from a real person's perspective, someone who's recently had the deep brain stimulation surgery. We're going to be talking through that process for him, the perspective of working alongside his movement disorder specialist, and kind of get an idea of what this actually involves, and hear it from somebody who has recently gone through this. So with us today is Eric Niemala. I'm going to say it wrong. Niemala.
Hi.
That's all right. Sorry about that. And his mom, Sherry, is joining us today. And then his movement disorder specialist, Dr. Cristina Ospina, which many of you have met before. She's been on many of our programs. And they're going to be having a conversation with us, talking through Eric's experience getting with this Parkinson's diagnosis, the decision to have deep brain stimulation, Dr. Ospina's role and perspective on helping Eric in making this decision. So great to have you, Eric and Sherry. Thanks for joining us. And of course, Dr. Ospina. And I want to start off with Eric, if you would just share a little bit about yourself.
Okay, well, my name is Eric, and I'm originally from California, Southern California. Then I moved out here to Arizona, like in 1993. So I consider myself a native of Arizona now. So, and I've been just going to school, and I was working at a mail order pharmacy before I figured out I had Parkinson's, and then after I was diagnosed, I just couldn't work anymore. So then that's how I had it. That was basically me in a nutshell. So.
Well, and you have your mom with you, Sherry. So it's good to have you, Sherry. And I don't know if you wanted to add to anything that Eric just said.
Yes, I can tell you how we first, I guess you'd say, noticed that something wasn't right. We were out walking, and I noticed that he didn't have a normal gait. Like, normally when you're walking along, both your arms kind of swing in motion, and his left side wasn't doing that. And so I said to him, swing your left arm. And he was like, well, it doesn't work. And what do you mean it doesn't work? Have your brain tell it to work. And it was that was the conversation as I remembered it. Okay. And Eric was born with club feet. And so he was in a cast. This is a little side story for his Parkinson's, but he was always off balance a little bit, because when you're in a cast for your first 13 months, your leg, your extremities don't grow the same. And so he always is kind of limping, and now he's not swinging his arm. And so I'm thinking something is just not right here. You need to go see your doctor. So he started with the primary doctor, who sent him to I can't remember what kind of a specialist it was, but I think what they first started doing was thinking he had, sort of like tendonitis, and they gave him some kind of a shot in the left side, thinking that that would help give him some movement on that left side. And then as all of this progressed, he got to a point where he couldn't keep up at his job with, you know, his typing skills, because things just weren't working so good, and ended up being on disability. So he's been on disability for quite a while. And all through this, we kept seeing, you know, the doctors, and we finally got referred to Dr. Ospina, who has helped us and guided us through what to do, what medicines to take, and monitoring that. And then we tried another procedure for a year, and that wasn't very successful. And then as we started learning about DBS, at first it was kind of like, you know, everybody uses Google these days, and they look things up, and then it sounds kind of scary sometimes. And so it took Eric a while to make the decision, asking questions and making the decision to do the DBS procedure. And then, you know, you get to a point where you're like thinking, I've got to do something to help myself, because I'm not getting any better. And, you know, when you take a lot of oral medication, that ends up with other issues like, you know, constipation and just everything that goes along with it. And then there's a lot of mood swings and anxiety. And when your body doesn't work right and it doesn't seem to be improving, you almost have this desperate feeling of what can I do to help myself? So we found out, and then COVID's in the middle of all of this, you know, we found, we live in Chandler, Arizona, and we found that there was a class once a month at our Chandler Regional Hospital that we went to, and we went to it a couple of times and just learned more about it. The presentation was by Jill Wallace from Medtronic, and we learned about it and had handouts, and we could see what took place. And I think Eric's biggest fear was that he was going to be awake through this procedure. And that was kind of a, oh my gosh, I don't think I could do something like that. But then he learned that, no, you're not awake. You're put to sleep and everything. So he made the decision to do it. And it was really exciting, because the day that we went in, we found out that he got to have the latest equipment. It was like something new that Medtronic had. And so his doctor was there, and, you know, it was quite a team of people that was going to do the procedure. And he was very comfortable with it. And all along through the learning process and getting, you know, his questions answered, my questions answered, is what led us to making the decision to go ahead and do this. And
That's
so
awesome.
it went well, and it was like night and day when the machine, you know, you take, I think maybe between 1 and 2 weeks to actually get the, you get a little battery in your chest, sort of like people with bad hearts have pacemakers. Well, the Deep Brain Stimulation has a little battery. And when we were in Dr. Ospina's office, and the Medtronic people were there, and they got the machine programmed, and you know what it's like if you have Parkinson's, what your dyskinesia is like. You're wiggling and squiggling and wiggling all around. All of a sudden, he was just like calm when the machine got turned on. So like I say, it's been like night and day. And from taking a lot of medicine 4 times a day, he's down to once a day. And still, you know, he gets a little wiggly at sometimes, but nothing like he was before the DBS. And he's able to control his movements. He's even been able to drive his car again, where he couldn't
So
drive
Sherry, do you mind if I interrupt you for just a minute? Because I want to back up a little bit. You've
Okay.
given us such a great overview. I want to go back to Eric for just a second. And because you talked about how you guys were out for a walk and you noticed he wasn't swinging his arms. And so you started seeing some things. So I'm interested, Eric, did you notice some changes in you? And if so, besides what mom saw and she pointed out, did you notice any things in you that were seeming to be off?
Physically, I knew I couldn't swing my left arm. So like she said, we were going to different doctors. One was told me I had like a tennis elbow, but for the shoulder. And then they told me to go to physical therapy, and we did that route, and nothing really was working. And then I talked to Dr. Pansing, which referred me over to Dr. Ospina, and then Dr. Ospina helped me out. He diagnosed me, and that was it from there. And so, and also my mom told me I used to scream, really like yell at night when I was asleep. Like this was years before I was diagnosed. And so I was probably having like REM, or rapid eye movement disorder then. Because I was like interacting with my dreams. And so I don't know, that I remember her telling me that. So I kind of think that was like her telling me that. It just told me that there was something wrong, but I just never really checked on it. So
Yeah, it was violent. He had this REM sleep disorder, and he would just yell and scream and kind of like act out physically. But since he's had his DBS procedure, his body seems to be more in control and able to sleep through the night without that.
And Eric, somebody wanted to know how long it's been since you've had PD.
Officially it's like 2010, 2011-ish.
Okay.
I don't know. I don't have the records in front of me. Dr. Ospina could explain more about that one if I have it, when I was officially diagnosed. But I've had the symptoms probably like years before that, a couple of years before that. So unofficially it's probably like 5 years before, 5-6 years, but then officially it's from 2010, 2011. So.
And sometimes when you don't know what it is, and you see a person even sitting in a chair and they're just kind of wiggly and their hands are kind of wiggling around, or and you don't really know what it is. And so that was, a period of time before he was officially diagnosed that he was exhibiting symptoms of this and not knowing what it is. And sometimes people are just wiggly and you're like, sit still.
So I'm sorry, Dr. Ospina, I would love to hear from you, like when you saw Eric and how he presented when you first met him, and maybe explain a little bit about some of the initial treatment.
Yeah, so Sherry's a very good neurologist. So she noticed the lack of arm swing, which is one of the characteristics for Parkinson's disease. And then for you to be diagnosed with Parkinson's disease, we're looking for 4 sort of cardinal features. So bradykinesia, or slowness of movement, and it's unilateral. It's always worse on one side than the other. So you notice that lack of arm swing is just one side. And so that's why many patients will say, well, I just went to my doctor's office. They had me walk down the hallway and they told me I had PD all in 5 minutes. Because once the patient has those symptoms, it's very easy to pick up. You can, make the diagnosis at Walmart. And so, but you have the non-motor symptoms, as Eric said. And then, the other thing is, Eric is a young onset PD patient. So he was diagnosed with Parkinson's before the age of 50. And those patients, you find that it takes them a lot longer to reach the diagnosis of Parkinson's disease because they're sent to orthopedics, physical therapy. What happened to Eric is very, very common. They're told you have frozen shoulder, there's something wrong with your rotator cuff, because nobody thinks that a 40-year-old has Parkinson's disease. So it takes them longer to end up seeing a neurologist or a movement disorder specialist. And then what Sherry was talking about, the REM sleep behavior disorder, is very, very common in PD, and many times is present years to decades before the diagnosis of Parkinson's disease. So by the time that you see a neurologist with a tremor, rigidity, trouble with gait and balance, you've already lost 60% of those cells that produce dopamine have already died off. So you've already had Parkinson's disease 10 or 15 years. And those are the non-motor symptoms of PD. So things like constipation, losing your sense of smell, like Sherry said, REM sleep behavior disorder. So that what happens there is that when you go to sleep and you go to REM sleep, which is your dream sleep, usually you're paralyzed so that you don't act out your dreams. But in Parkinson's disease, that paralysis doesn't take place and you're free to act out. So you can talk, yell, scream, kick and punch because you're acting out your dreams. And that's called RBD, or REM sleep behavior disorder. And that's present sometimes decades before the diagnosis of Parkinson's disease. And then mood changes like anxiety and depression are very common. So when we first see a patient with Parkinson's, we'll see what their characteristics are. Are they still working or not? That sort of makes us decide, should we start levodopa first? Should we start a dopamine agonist? Should we start Azilect? And then we decide. It's very individualized depending on what the patient's symptoms are and if they're still working and what kind of side effects they may or may not have. And then one thing to highlight with Eric, something that delayed our sort of journey towards DBS was that Eric was in this banner system where we were locked out of using surgeons that were outside of the banner system. So I think it's really important, especially for patients who are on Medicare and choose Medicare Advantage programs that lock you into a network, that when you're choosing these insurance programs, that you look very carefully. Is there a network that's locked in, or can I go anywhere in the United States and see any Medicare doctor? And what sort of therapies are available on that network? Can I have Rytary or any of the advanced therapies? And who are the surgeons in that network? Because, for years we tried Banner to give us an out-of-network exemption so that we could go and use the surgeons at St. Joe's, and they always said no. And so it's really important that now we're lucky in Phoenix that we've got excellent surgeons in almost all of the networks. So now if you have Banner insurance, you can see Dr. Bina and there's no problem. You're not locked out of getting DBS. But, I think that's something to look into, because especially when you're first choosing an insurance company, you're not thinking about these things. But if you have a chronic disease like Parkinson's disease, and you're going to need advanced therapies like surgical therapies, and then the pumps and those sorts of things, and then medicines like Rytary that are branded, that you want to make sure that you have access to all of those therapies. And that if you're considering DBS, that the surgeon that you want is in your network, and the insurance is going to say yes, that we're not going to have to fight it for years, or have to switch you out of your insurance every, in November, so that you can enter another network. Remember that straight Medicare, you can go to any doctor anywhere in the United States. There's no network that you're locked into. If you choose a Medicare Advantage program, then you're locked into, Humana Gold or whichever one you chose. And that network, especially in Arizona, can be very restrictive. So if you're in Pima County, you can't see anybody in Maricopa County. So remember, like in Parkinson's disease, you also have a higher risk for melanoma. If you develop melanoma, if I want to send you to MD Anderson in Houston, I can't do that if you're stuck in a network here in Arizona. So that you want to have the most choice available to you for your therapies as far as advanced therapies.
And that's a great point. In fact, it's important right now because we're in the midst of open enrollment, which is almost close to being done.
It ends December 6th.
Yeah, so we're almost there. And, it's an opportunity each year for you to evaluate not just, the neurosurgeons and the movement disorder specialists, but just like Dr. Ospina said, even, considering your drug plans and all of that. So thank you for bringing that up.
And I think that and DBS, we rather do it earlier rather than late. 20 years ago, it was like the last therapy we chose. Today, we use it earlier because the more cells there are to stimulate, the better the treatment works. And so that we don't want to delay it by a year or two while we're waiting for November to come to switch you out of your network so that you can avail yourself of the DBS surgeon in your county. So yeah, that's something to think. And then we would have been able to do DBS earlier in Eric's case if we didn't have that banner problem.
Right.
And
Now
somebody
my
wanted to know
insurance
if there's
takes
an age.
both.
I'm sorry, go ahead.
I said, now I just found out my insurance that I have now goes to both Banner and Dignity. So I could, if I go to known that with Cigna, I could just taken that and we didn't have to go through all that problem back in when I.
But we feel that the problem was there for a reason, because by the time everything was clear in our network, the Medtronic has developed newer equipment. So sometimes you feel that was a blessing to have it prolonged, because through all that experience, we feel that now we were at the right place at the right time, and
Awesome.
everything is really working well.
So Dr. Ospina, we did have a question if there was an age limit to having DBS. I know you just mentioned the earlier, the better, but is there like a cutoff period or an age cutoff?
So there's not really an age cutoff. So it's really your functional age. Can you undergo surgery? Are your heart and lungs good? My earliest DBS, she was in her 20s. Most of our DBS patients are in their 70s and 80s. And then I think there was one lady in Florida who had DBS for essential tremor, and she was 104.
Oh.
So, yeah. So it's not your chronological age, it's your functional age. And then, as Eric said, if you're west of the Mississippi, we can do it asleep. If you're east of the Mississippi, they're still doing it awake. So again, like Sherry said, go to the classes, be well informed, and that way you can get the best therapy for yourself. If you don't want an awake surgery, you go find a program that does it asleep, which is much easier for the patient. And then there's 3 different companies that make DBS hardware, and they do slightly different things. And so that you want to research that and see, what's the best one for me? Do I live in a remote place? Do I want something that has remote programming, or do I want the latest and greatest in the newest technology? Eric has the Medtronic's Precept, so it has brain sensing. So it senses when your levels of dopamine are low. And then our hope is that in the future, we can close that loop, and that the DBS itself can then sense the beta and then add more stimulation at that time. So it's more dynamic. And then because once we put the leads in, we're not going to take them out unless you have an infection, that those are your leads for life. What we can upgrade is your battery. So that can be upgraded, but the leads are the ones that you're going to have for the rest of your life, so that you want to pick the right one for you.
And usually they say the batteries replace every about 5 to 7 years. So when you get the battery put in, so.
Right, and there's also rechargeable batteries if you want never to replace it again. I mean, those are 15-year batteries. So there's different hardware, and then it's good to see what's out there and then what you feel is best for you, and then discuss that with your surgeon and neurologist.
So we had a question. They wanted to know, what are the symptoms that would make a person choose DBS? So I'd love to hear Dr. Ospina to answer that, but then I want to go to Eric and I want to hear what symptoms he had and then how he got to that aha moment of deciding to go the route of DBS. So Dr. Ospina, can you first share a little bit of?
Sure. So DBS works really well in controlling a tremor that we can't control with medication, or we have to use such high doses of medicine that you develop side effects like low blood pressure or hallucinations. DBS is excellent at dialing out that tremor. And then if you develop on time with dyskinesia or involuntary movements, that every time you take a dose of levodopa, you have on time, but then you have this period of dyskinesia after that. So that allows us to take the medicine without the dyskinesia, or lower it a lot less. In Eric's case, he was taking a large amount of medicine and lots of dyskinesia throughout the day. So he didn't really have too much of a tremor. So now with the DBS, we're able to take the medicine without all of that dyskinesia. And in his case, which is not the case for everybody, we've been able to decrease the amount of medicines that he's on by a great deal, so that he doesn't have to take as much medicine as he did before DBS. And that when he does take the medicine, he can have on time without dyskinesia or all of that wiggliness. So those are the two main things. Everything else that you get, we just call frosting on the cake. So if your RBD got better, your insomnia got better, all of that is frosting of the cake. We can't say DBS is going to do that. So it's basically tremor, dialing out the tremor and dialing out the dyskinesia.
My aha
So Eric,
moment
what was the aha moment for you?
mine was one day I was just having massive dyskinesia. It felt like I was running a New York Marathon like for 4 days straight, just running that all day. And I was getting real sore, like just from doing all the wiggling. And also the prior procedure that I had wasn't really working out for me. So I said, you know what, I'm done. I just need to go do this. And I just need, so we went to Dr. Ospina. We set out the plan to go get this procedure done. And then that's how I came to get the DBS. I was just sitting there one day, just not feeling really well and just really wiggling. And I just had to go talk to Dr. Ospina and see if I was a good candidate for it.
And what was the process like for you, Eric? Once you had that discussion with Dr. Ospina, can you walk us through like what your whole like workup into the actual surgery was like?
Okay, yes. What I had to do is then we had to get blood work done, so to see how my like kidney function was working, how my lungs were working. We had to do a physical. So I went to my primary doctor for that, and then we went over to see the neurosurgeon, her name, Dr. Chen. I think she's one of the best neurosurgeons out there. And she turned around to the person that started doing DBS here in Arizona, Dr. I think Ponzi, or if I don't know how to say his last name, Ponzi, or Dr. Ospina might know that one.
Uh-huh.
And then we went to talk to her. She was 8 months pregnant at the time, and that after seeing her 8 months pregnant, that kind of gave me that one way having open brain surgery. I was worried that she was gonna have the baby when she was performing the surgery on me. So
We didn't want to hear, oh, my water just broke.
yeah, so I was put on, or like when I wake up, she didn't have those.
She was fine.
Yeah, she was fine, but I didn't want to hear her when I was waking up. She misplaced this down so I could. She had one of those false labor pains.
She was just really, really a nice person.
Yeah.
And her expecting a baby was just, we kind of made these little jokes about it, but everything was fine. There was no concern with her. She's a very, very well educated, very skilled doctor. And so it went really well.
And then after first speaking with her, then I had to go to the hospital, get their tests done, like go do that and CAT scan and x-rays and whatnot. So the doctors could map out my, or they want to place the posts and all that. And so I want to do that. And then 2 weeks later, after that, I went to the surgery, to the hospital, checked in, and then they went to the pre-op portion of the procedure, and then they were totally nice, and we were all having fun down there. And also both Jill and the other person, Joey from Medtronic, was there too. So they were there at the procedure. And then they put me out. Next thing you know, I was downstairs in the recovery room, and with the nurse sitting there typing away at the notes, what woke me up was to hear the click, 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 the computer keyboard of the post-op nurse was just sitting there. And we just after that spent one night in the hospital, and that was basically it. it's just like they keep you, and they did the whole procedure because what I was told, they like to do it at two procedures, but I only did it once because due to COVID, the hospital I was at said they go ahead and just do the whole procedure once, do the whole thing, but normally they said they could do it twice. Put the posts in and then they'll attach the battery later. But since the COVID epidemic was going around, they told me to do all I wanted is a 3.5 hour procedure, and so
It went well.
well.
So were you awake then or asleep?
I was asleep during the whole procedure.
Okay.
Yeah, so because our hospital just said, the hospital I went to said, just come out and have them do the whole thing at once. So
And then once you had the neurostimulator implanted, how long was it before your programming started?
it was 2 weeks after I got everything put in,
All right.
and then we went back to Dr. Ospina, and she, with the help of the Medtronic representatives, programmed my battery and everything, all my dyskinesia just totally stopped. It looked like I did a 180. I shouldn't know before they
We
turned
were
on.
all amazed.
Yeah, before I was really wiggly, then all of a sudden I just became calm, and it was really good. It was really awesome.
So I want to dive into that just a little bit, because I want you to kind of give us a picture of your quality of life, your pre-DBS experience, and then your post-DBS, when you started the programming. And I know that it doesn't, magically get perfect the first time you program, that it takes several times, but can you share a little bit about that pre and after?
My pre was I couldn't really basically do anything. I couldn't got my food or anything because of the wiggliness. And then afterwards, it was just like I could start driving again, and I would only go drive short distances to to the pharmacy and to the bank, and that's it. And then after, it's just like now I could drive a little bit. I could now cut up my food, and I could walk better. And so it was like a turnaround, 180% turnaround.
So there was a question that came in from Sarah. She says she still sees some of your movements. So she wants to know if that's consistent with you, or is it because you're nervous a little bit?
I'm just nervous.
Today?
This is not, speaking in front of a larger group is not my strongest point. So I'm just kind of nervous. So when I get really nervous, my wiggliness tends to come out. So it's just me being really nervous, and communications is not my strong point. So
Yeah. Remember
You're doing
that
fabulous.
Parkinson's disease is the poster child for the mind-body connection. So everything that you're thinking, feeling gets reflected in the Parkinson's disease. Normally, Eric is nice and quiet, but any kind of stress will bring out your PD symptoms, whether they're tremor, dyskinesia. And so that's why you can see that even though most of the day you feel well controlled, if you're excited or watching an exciting movie or talking on Zoom, that tremor or that dyskinesia might be a little bit more prominent.
And I'm not sure, but I think they might have fallen off.
Sorry, we got
Oh, there
kicked
you
out.
are.
We're
You
back.
moved.
We got
All
kicked
right.
out, so.
So it has been a positive experience. And how many programming appointments have you had so far?
3,
Great.
I believe.
I think two.
Oh, I think it's
2 or 3.
2 or 3.
Mhm.
So, but I feel a lot better, and so it's one of the best decisions I ever made in my life. So to get this done, even though I was totally afraid of having brain surgery, but I got over those fears because I had met with the neurosurgeon. She put me at ease, and so Dr. Ospina put me at ease, and the 2 reps put me at ease, and so I just went in, just have them do it, let it do it, and then and
Everything's healed.
everything's healed. You can see these little bumps up here. I always tell people, I guess if I introduce myself, I say, hi, I'm Eric, formerly known as Satan, because they cut off my horns. So, and so.
Well, when you're bald,
Yeah.
you can see your bumps and your scars, but we have a friend who's had the DBS because she had dystonia, and you know, she has a full head of hair, so you can't see it, which is fine, but everything is healed up, doesn't bother him. And is there anything that you can't do, you think?
Nothing.
And that's a question. Someone wanted to know if there are any activities you would like to do that are not recommended with these devices. And if you've noticed any physical objects in or on your body, does that opening of your head or that area where your implants were, does that ever bother you?
No, at first, they were real sensitive after the surgery, because I just had major surgery healing. And the battery scars right here. And those two places were like kind of tender for a while after the surgery, but then now nothing bothers me anymore. But any sports, I wouldn't. Football, I wouldn't play, because anything that has to do with something like contact sports, I wouldn't do, because I don't want to take the chance of having to get like whiplash or my head moving, and then even more brain injury due to that. But after that, I could probably go swimming, cycling, just whatever I want. Other than the contact sports, I can basically do anything else.
Right, so that's right. We have patients who scuba dive after DBS, who ski after DBS, but we don't want things like contact sports, like football or rugby, anything that could lead to a lead break or any break in the wire. We want to keep away from that. But nothing pokes out of the skin or anything like that. Everything's under the skin. And then you do have a patient programmer, and it talks to it through Bluetooth. So we don't have to worry about any of those things.
Yeah.
Dr. Ospina, could you share a little bit from your perspective about the whole programming? How long does it take for you to work with a person who's had the implant? What should somebody expect from that?
Yeah, so actually Eric programmed very quickly. So he's not the typical case, because basically in his first programming, his DBS was dialed out at a very low stimulation. So usually we tell patients that we like to wait about 3 to 4 weeks after the second stage of the surgery, or the first stage of the surgery. Remember, usually the surgery is 2 stages. They put the leads in, and then a week later, they put the battery in and connect it to the leads. Eric was lucky that he was still able to get a 1-stage surgery where we did everything in 1 stage, which is preferable. And then we see the patient 4 weeks later. We wait for all that swelling to go down and then start the programming. And then usually the program, we say it takes 3 to 4 months to make sure everything's done, and we dial out everything. And it can be done faster if the patient, so you have a patient programmer. So the patient is allowed to go up or down on their stimulation if they want to. And if they do that and they can climb up the stim a little bit faster, then we can shorten that interval period for programming to maybe 2 months or so. And then at that time, we are reducing your meds if we're able to, and then we're slowly increasing the stimulation. In most people, we can't crank it all the way up because your brain just can't tolerate a high stim. So we do it very gradually. And then we just sort of see where we are and go from there.
And these are what I get from Medtronic. See, I get this. I just turn it on. You get this phone. It's a Samsung phone. If you see it, this is one.
Programs.
This is what programs me. This is what I can control for my implants with, and this is the thing that reads between the phone and my battery. This little mouse contraption. So I could, when I feel like kind of dyskinesia, like now, I could just go ahead and program it. Or Dr. Ospina sets like a limit, like a I don't know what they call it, like a maximum dose to it. So, and I can adjust myself depending on how I feel for the day and how my medication is working. And so this is what I get to control it. And then Dr. Ospina can go on her thing that she got from the Medtronics. She go on there and she could look at what's been going on through my brain and how my Parkinson's has been doing.
So yeah, so now today it's very intuitive that what the patient has, the patient programmer is an iPhone or a Samsung phone. It's much more intuitive than what it was before, and it's much easier to use. And so if you want to have control over your DBS unit, you can, and you can go up or down on your stimulation, and the doctor puts in some parameters. And then we can also program in different groups. So for patients who have essential tremor, where we know that high stim causes some dysarthria or trouble with the voice, we can have different groups if you want to sing in church, if you want to play golf, if you want to use a screwdriver. And so that way you have more control over your stimulator, and you can have different groups to do different things, especially for essential tremor patients. And for DBS patients, for Parkinson's patients, they usually keep it on 24 hours a day. They don't turn it off at night. And we have rechargeable units as well, so we don't have to worry about battery life so much anymore. And then if you have to replace the battery, that's a very easy procedure. It's just like replacing a pacemaker battery. It's 20 minutes in the OR, it's outpatient, you go home the same day. So they just open up the little pocket, put the new battery in, connect it, and that's it. So it's a very easy procedure.
We had an earlier question, Dr. Ospina, because you mentioned essential tremor, and somewhere along the line we mentioned briefly.
Where's the audio?
So I think Anissa said it was slow down, but I think, yeah, so there's 3 different reasons why we would use DBS. One is essential tremor. So and that differentiates itself from Parkinson's disease. It's a familial tremor. It's an action tremor, whereas in Parkinson's, it's a resting tremor. You're watching TV and your little pinky goes or your thumb goes. In essential tremor, you're picking up a fork or a cup and you have a lot of shaking, and it's usually both hands, and it can involve the face as well. And so we do DBS for that. And then also for dystonia, whether it's young onset dystonia like T1 or dystonia from other reasons, then we can do DBS for that as well. And then they all have different places in the brain where we put the stimulator to control the different kinds of tremor or the dystonia.
I think I'm freezing occasionally, so I apologize for that. We also had a question, and I think this is a good general question for you, Dr. Ospina, if there's anything that would disqualify someone from being a candidate for DBS.
Yeah, so one of the things that we do pre-op to, as Eric mentioned, you do, all of your blood work, and that's with the EKG to make sure that you're a good surgical candidate. And you do your CAT scan and MRI to help with the mapping, but we also do neuropsych testing. So we know that if there's any trouble with dementia or early dementia, that doing brain surgery is going to make that dementia worse. So we screen out anybody who's sliding into dementia. And so that would be a contraindication in Parkinson's disease for somebody to have DBS. That's why we prefer to do it early, so that if 10 years later you develop dementia, that stimulator is already in place. It's still working. It works 24/7. And when you're no longer able to tolerate higher doses of medicines, you still have the DBS on board to help you with your PD motor symptoms. So it's one of the reasons we like to consider DBS early in the patient's course rather than later.
And I'm interested, Dr. Ospina, in terms of Eric, because you've been with him through this whole process. You saw him when he was just on medications and trying different things, and then having DBS. How do you think, or what have you seen as far as changes in him? And I know that a lot of times physicians will do, UPDRS or things like that. So you actually have something tangible to say, well, this was before and this was after. So can you talk from a clinical difference, what you've seen in Eric?
Yeah, so remember that Eric is not the typical patient. So Eric had a very, very good response very early to DBS. So within the first programming, we were able to dial out the dyskinesia, which usually does not happen. And he was able to decrease his medicine by a lot, which also usually doesn't happen. Only it happens if we do it early in the DBS, in the Parkinson's course. If you've had Parkinson's 10 years or more, like Eric did, it's very unusual to cut the medicines by half or more. And we were able to do that in Eric's case. So he's not the typical case. So he takes very little medicine today compared to what he took before. And he has very little dyskinesia throughout the 24-hour period, unlike what it was like before.
And Eric, I lost you on the screen. You've moved around a little bit, but I know you're still there.
I'm
So
on the top row, so.
there you are. I keep moving things around here. So I know we talked a little bit about your before DBS and then, after, and it seems like it's been pretty astounding for you. It's been life-changing. So tell us a little bit about what you're doing now that you weren't doing before. You spoke a little bit about it, but I would love to hear really what has your life been like since DBS?
After getting the surgery, I just felt like I wanted to go help the Parkinson's community, especially people who were diagnosed under the age of 50. I want to go help promote the DBS system with people under 50, so they won't be scared and not think it's like some older generations type of disorder. I don't like saying disease because it sounds like I caught it or something. But so, and also I wanted to go back to school to become a neuropsychologist so I could help understand to help people to understand why this is happening, help understand what's going on inside of their brain, and so I'm going back to school. So.
That's awesome. So if someone was considering DBS, Eric, what would you say to them? What kind of advice would you give them? I don't know if I lost him or if I'm frozen.
We lost him. I'm gonna get him back on.
Okay.
I think the most important thing for people considering DBS is to talk to other patients who've had DBS. So they can tell you the good, the bad, and the ugly, so that you can make a well-formed decision. And here in Phoenix, all of our DBS surgeons, they all have classes. So we always have you go to the class so that you can be familiar with what is DBS, what's the surgery like, how does it all work? And then we have a list of our patients that have had DBS, and we have you talk to them so that you can ask them questions and make sure that this is the right therapy for you and that you feel comfortable going forward with DBS. So you want to have a well-informed decision. Go ahead, Eric.
Yeah, I just say just talk to your neurologist and go to the classes, get all the information, and then if you're eligible and go do the tests usually run about 2.5 3 hours. The psychological test usually runs about 2.5 hours, 3 hours at the most, depending on who you have, and just go through all those steps to see if you're eligible for it. Then if you are, go ahead and talk to your neurologist, and so she can set it up, refer you to a neurosurgeon, and then I say go for it. If you're able to do it, I just say go for it, and let it just take its course. So.
And Dr. Ospina, I'm sorry, Eric, did you want to say something?
If you can't do it, then talk to if you're not eligible to do it because of dementia and all that stuff, just talk to your doctor and just do other treatments they could do. So that's what I say. If you can do it, if you're eligible for it yet, then just go ahead and go forward with it. So.
And I don't know that I asked this question, but it makes me think of it now. Who brought up DBS? Did you bring it up to Dr. Ospina, or did Dr. Ospina bring it up to you?
Actually, I don't remember who brought it up to each other.
Do you remember, Dr. Ospina?
So we had talked about it, but then we had the Banner problem. So for several years, we were not able to get Banner to give us an out-of-network, exclusion to use the St. Joe's system. And then we tried another therapy that didn't work. And then he switched the insurance and then was able to go to Chandler and then have DBS there.
Okay, that's great. And Eric was saying if you can do it and you are, qualified for it, then go for it. So we did have a question. Would AFib disqualify a person? Is that something that would be a concern?
Right. So AFib is sort of an irregular heartbeat that you get put on a blood thinner for. So basically all we would do is take you off the blood thinner before the surgery, do the surgery, and then put you back on it. So it's not a contraindication. We just have to manage that blood thinner, make sure that it doesn't cause excess bleeding throughout the surgery. And then, you decide the risk ratio. The reason that AFib patients are put on a blood thinner is because you can form clots in the heart that go up into the brain and cause a stroke. And so that we want to know that, while we're off that blood thinner, there's the higher incidence of stroke, but the benefits outweigh the risk. And so that AFib is not a contraindication. Or anybody who's on any blood thinners, we just take you off and then put you back on.
And we did have a question. They wanted to know, how would you determine if your insurance will cover DBS?
Well, I think I guess maybe only once you ask them, or once we put in all the paperwork and then they deny it. And so, but I think what you want to know is that you want to know, like, what is the network? Who are the physicians and surgeons that I can see in this insurance? And then you can see, are all of the big hospitals in there, or is only Pima County in there, or only Maricopa County? And in Maricopa County, is it only Honor Health, or is it only the Banner Network? And then you need to ask, well, at that time, there wasn't a DBS surgeon in the Banner Network. So then, okay, then I'm not going to choose Banner if I want DBS. Today, there is a DBS surgeon in the Banner Network, so that's not an issue, but it was before. So you want to see in your county who the DBS surgeon is, what network are they in, and does your insurance cover that network?
I have to add on to Dr. Ospina saying, just call your insurance and have them mail you out the paperwork to say, if they try to deny it, you can tell them, hey, it's in your whatever laws or whatever in your cover, in your explanation of benefits, saying that yes, you do cover it and this is what you can do. So always get paperwork from the insurance company. So if they try to backtrack on you, you can just say, hey, no, this is right here. So that's what I have to do.
Yes, because sometimes just a telephone call.
I don't know if it's me freezing again or them. I think
it's Cyber Monday. Everybody's shopping online.
I think it must be because we're all struggling today.
Right.
While we get them unfrozen, I did have a question that might be something that you could answer, Dr. Ospina, because we had mentioned that this is obviously, it's brain surgery, so it can affect the brain, and we do neuropsych to rule out any dementia or anything like that. So this person, and I think this is a good question, wanted to know if there's been any changes in Eric's thinking or memory, and is that something to be concerned about post-surgery?
No, I haven't noticed anything. We can ask him, but we would be seeing changes if we did the neuropsych testing before and after. We can see some mild cognitive changes, but it's nothing that would impede having the surgery. So it wouldn't be a contraindication, but you do see changes on neuropsych testing.
Okay.
So always with any therapy, we always want to make sure, do the benefits of the therapy, whether it's medicine or surgery, outweigh the side effects or risks of the therapy? And then only the patient can make those decisions for themselves.
And is someone able to have an MRI after having DBS?
Yeah, so today, most of the platforms are MRI compatible, so that you should be able to have an MRI. And now it's much easier on your patient program, where you just sort of click on MRI. It's not the complicated procedure it was before. So patients with the older MRI, some of them may not be able to have MRIs, but all the new ones should be able to.
Yeah, actually, they told me I can have an MRI, but I have to turn the system off, like for however long it takes, and then I can turn it back on. But for having like a CAT scan, anything that has anything to do with radiation type of imaging,
So it'd be
I could have it what was that, Dr. Ospina?
Yeah, so you can have a CAT scan. So anything that has a magnet,
Yeah.
like an MRI, we want to turn it off,
Off.
and then you turn it back on afterwards. The same thing, you know, if you go to the ER and they're going to do an EKG, it'll have a little blip. Then you can just turn your device off. They can do the EKG and it comes out fine without the pacemaker blip. But now it's very easy for the patient to control their own stimulator and turn it on and off without having Medtronics to come into the ER or the OR to do that stuff.
So yeah, anything they said also anything radio, you don't have to turn your machine off. If you get like an X-ray, a CAT scan, anything to do with radiation, so you don't have to turn it off. Any radiological pictures that they have to take of your whole body, you keep that on. Anything else beyond that you have to turn it off. So.
Right, and ultrasounds are fine as well. So you can get an echocardiogram or that sort of thing.
That's very helpful to know. And Eric, we lost you for a second, and Dr. Ospina gave her perspective on this, and I think this will be kind of our last question. But since you had DBS, have you had any changes that you've noticed in your own like thinking or memory?
Yeah, my thinking's been like, I feel a lot better. I have a more positive outlook. And before I was like, oh, since I had this kinesia about, I was thinking, oh, this sucks. My life is gonna not change and everything like that. So now once they put the DBS system in my head, I feel like I got my hope back, that I feel like I'm a lot more happier than having it in, not having it in. And then, oops, I'm out screen door. And then, I don't know, just the way of thinking, just be more positive and be more happy and just having a better quality of life. It's just better like that. So.
Well, I think that's like, I don't know that you can end it on a better note than that, is, saying that it's given back your quality of life and your hope. I don't know if either you or Sherry or Dr. Ospina have any final comments that you want to make.
I just say, if you need to go get if you have tremors or whatever things that you have, let's talk to your doctor and see if you're eligible or your neurologist. Go out and talk to them and see if the DBS is a good choice for you, and go ahead and follow that line so you could go ahead and get the surgery and get a better quality of life.
I think maybe what I would add, I started to say before we bleeped out again, was that don't just call and get verbal information over the phone. Get a document from your insurance company as to what they cover, and keep asking questions, because that's how you get the real answer. And working with your doctor and doing your own research to find out about this procedure is what will convince you that this would be a good choice.
Any final comments from you, Dr. Ospina?
No, I agree. So you want to have a well-informed choice, and we always like you to see and talk to other real-life patients who are on DBS so that they can tell you the good, the bad, and the ugly. So you want to have a well-rounded idea of what you're getting into.
Awesome. Well, I want to thank both really appreciate hearing from somebody who's actually gone through it. And of course, Dr. Ospina for giving the physician's perspective. And I love that you guys are already physician and patient together. So that really helps us to see that dynamic. We do have another program coming up in our series in January. And I know there were some questions about essential tremor as well as dystonia. And we're going to be covering all three indications: Parkinson's, essential tremor, and dystonia. And we'll have patients that have surgery with each of those diagnoses. So stay tuned for that. It's coming up in January. And if everyone would just give that wave of gratitude to Dr. Ospina, to Eric and Sherry. We thank you so much for being a part of this conversation today. I think it was really helpful. Thank you so much, everyone. I thank you for joining us. Have a good rest of your day and go shop for Cyber Monday.
See you.
Thank you.